So we're going to go over basically a full body assessment when the patient comes in. You do your history. Where is the sheet? One of the sheets here. You do your history, and then you take down all of your notes.
Here's my sheet.
Then you do your observation, your inspection. You have the patient stand and not move for a few minutes. You inspect and look for asymmetries. Very simple. Inspection is a lost art. It's very incredible what you can see with your eyes if you just sit and you just relax, chill out, look at the patient, have them not move. You'll see all kinds of things if you just allow it to happen. You'll see so much. So inspection is the next thing, not to be underestimated. Take your time with it. Then you begin your examination, ranges of motion generally. So there's general things right off the bat, just standing up, taking your shirt off. We're going to look at all the general things here. Okay, we're going to look at everything from the feet. One foot pronate more than the other. Is there some coccygeal? Is there a change in the hip levels, shoulders, the ears? We look at the spine to see if it's too flat or if the curvatures are there, to see if there's some distortion in the curve, some twisting. Obviously, you do standard tests like bending forward, seeing if one side is higher than the other, coming back, seeing if there's any pain in that range, any pain in extension. Usually hold your hand there. And of course, lateral flexion, measuring how far the hand comes down on either side to see whether or not you've got a shortness of quadratus lumborum, which is quite common. So that's basically what you're going to do from there. And then if there's any other tests that need to be done, reflexes or skin sensation tests or anything like that, you can do that. But just from a very basic perspective, now you're going to just get into a biomechanical assessment of the spine, and then after that you're going to get into your neuromotor, neurokinetic, Trigenics assessment. The spinal assessment is really only necessary if there's a back or neck problem, but whenever there's bilateral weaknesses, you're always going to go to the spine as well and check it. So with respect to the spine, come on over here and just sit down facing that way. Ranges of motion again in the neck as well as in the lumbar spine. We're going to do, first of all, lateral flexion to one side and lateral flexion to the other, holding the shoulder down when we do this. So that's your first move. So I can see that he's not moving as much to the right. You can see this popping up. You'll feel that. Let him know that you know where it is. That's quite tender, isn't it?
Yes.
He'll say, yes, it is. The other side's not nearly as tender. You can see the difference here in how much it flexes. So I'm going to go, and then I'm going to mark down on my chart. I'm going to mark in on the left side. We have, now your chart's going to be marked a little differently. Unless I've got one of these, which I might have.
Here's mine.
You didn't use it?
Oh, yes.
Yeah, you've used it. I'm not sure if there's another one. Anyway, that's fine.
This is mine. This is mine.
Oh, that's yours then. Perfect. There we go. Okay. So we're going to mark in on the chart, left middle scaling. There it was. I just marked it in. Pretend these other markings aren't there yet. Now I'd have one marking already on there. Then I'm going to go into Splenius Capitis, checking this way, and left and right. It'll just be right and left, respectively. I can feel and see that the right side is shorter. In this case, you can feel it as well, going up here into the mastoid, quite tender. So what I'm going to do now is I'm going to laterally deviate him the other way and check for the corresponding semispinalis. Usually the two of them are going in tandem because they're going in the same line. So usually the right splenius will be short along with the left semispinalis. The semispinalis is the muscle most responsible for headaches, neck pain, things like that, with small rotatory muscles, right, intrinsic muscles, and he's got them right here.
Yes.
Very, very tender. This is all semispinalis. What feels like a bone is actually severe contraction of semispinalis. Now, if I go on the other side, he doesn't have it. He's got softness. So he's got semispinalis here. So now I'm going to mark in semispinalis on the left. You're looking at this with the camera, right? Or no? I'm marking in semispinalis on the left, and we're marking in Splenius on the right. Okay, we marked in already left lateral scalene. We marked in semispinalis on the left, Splenius on the right. Notice that they're both in the same angle. So that's very, very common. Now we might have some weakness. If you have weakness of the posterior cervicals, it's really usually a fairly serious problem, usually a disc problem or something. Hold it there hard as you can. Now, I just said that, and I'm quite shocked that after this whole weekend, you've got a weakness there that nobody saw before.
Do it again. The day they're going to test it.
That would be, hold it this way. You see, this Splenius Capitis is short. Now here's a typical reciprocal innervation type of situation. This one is weak. You can't hold it. If I bring, if I shorten the right semispinalis, I can try to break that from here, hold it here, more central, and I can't really, but there's a lot of other muscles in there as well, so it's really difficult to, I think, do a test for semispinalis with respect to strength, but definitely that left splenius is weak. We're going to mark the left splenius in. So here we are as we're going along, and now we're going to mark in the left splenius as being weak. So see, the left is weak and the right is short. Okay. Then we're going into the upper back muscles, which are also neck muscles, primarily levator scapula. You're going to palpate. Usually the angle of the scapula is quite tender. If there's a problem there, there's been some fibrotic adhesions there from static loading stress. He's not that bad in there. It's really splenius that's a problem. If I turn his head the other way and I elongate this muscle here, then I'm going to get a feel for upper trapezius. And I can go the other way as well. Maybe he's a little bit short in there, but it was mainly the splenius and semispinalis, which are short, so I was checking for that. If I really want to check for upper trapezius, of course, I can try to break it this way. If I really want to check for scalenes, same thing, only I'm let it go, trying to do that. Okay? Alright, now you can get into shoulders and chest, bilateral pecs, lower, upper, minor, subscap, infraspinatus. This is all length testing. Okay. This is, turn your thumb out, this is rhomboids, relax, rhomboids. Turn your hand down and internally rotate. Now this is, you see the difference here is middle trapezius, and if I come down and across, I'm checking lower trapezius for length. Okay, good. I'm also checking posterior deltoid and some of the external rotators for length. I'm checking the shoulder, doing the Austin latissimus dorsi length test. Trigenics method of doing it. Okay, and we can go into other length tests such as teres major, and then we can get into all the strength testing from there, holding it up. Okay, deltoid, what happened there? So he's got a weak deltoid on the right. I'm going to mark that down. Marked in the right deltoid. it is. So this is all in there.
You test that again?
And then we're going to check anterior, hold it. Posterior. Triceps. Okay. Infraspinatus. Minor. Subscap. Lats. Straighten the elbow. He's weak in there. Check the other side to confirm if it's keep the elbow straight. Elbow straight, elbow straight. He's actually weak bilaterally. So straight to indicate bilateral. And I'm going to mark in the latissimus dorsi. It's being bilaterally weak, which means I'm going to have to go to C6 to 8. We're going to check out what's going on in there. And I'm going to palpate by pressing into the spine as there's a problem here. It doesn't move right in there. And if I do the semispinalis, I also find that there's a knot of muscle in there on the semispinalis as well. So there's a bit of a problem there. One of the things that I can do with this is if it's localized, I can actually do a TL on that semispinalis, which may mobilize the lower segments, which may also help restore some nerve conduction down through to latissimus dorsi. We're going to see if that works. You're going to come back this way as you breathe out, fairly hard, breathing in. Go. I'm just doing this right now. Let it go. Relax. Breathing. Real practice, I might wait until I've done the whole assessment before I do this. Breathing. So we're doing a heavy duty